So it's my great pleasure to be with you this afternoon and to talk to you about this very important topic of education for a safer Ramadan. I thank Dr. Wiam for this kind invitation, and I wish you're all having a wonderful educational experience. I'm just waiting for the slides to pop up. So when we talk about fasting in Ramadan, as we have just heard from Professor Hassanin, fasting is a very personal, religious, spiritual decision of the patient. And I'm sure you face in clinical practice patients who insist to fast, who feel really upset when you ask them not to fast. And our role as clinicians, in whatever role we play, be it a nurse, a doctor, a dietitian, a pharmacist, our role is not to give permission or prohibit a patient of fasting. Our role is to protect them and keep them safe regardless of the decision they make, is to understand how to support them to the best ability. So that's where education here has a pivotal role in our support of patient safety. I have nothing to disclose in relation to this talk. And during this presentation, what I will focus on is why diabetes in Ramadan matters and why does education matter. We'll cover physiology so that we understand the risks that our patients are exposed to. We will again touch upon the risk stratifications that Dr. Hassanin just explained, and I'll explain why education matters as the core intervention to protect patients and enhance their safety, and then give you some practical advice on the use of medication and technology with take-home messages at the end. A lot of what I explained today comes from the DAR guidelines. We are awaiting eagerly for their most updated guidelines that will come early this year in 2026. So the latest one is what you have the QR code for there is from 2021. Of course, diabetes matters because of its global burden. According to the latest IDF Atlas, the 11th Atlas from 2025, 589 million people around the world live with diabetes. And there's disproportionate increase of diabetes within our region of Muslim countries. And we therefore understand why diabetes in Ramadan matters because diabetes is a common problem and it's common among Muslim countries. Also, because of the variation of Ramadan from year to year in months, you might have patients who are exposed to longer hours of fasting, more dehydration, more heat. We're lucky in Bahrain and this region to enjoy this year a lighter, shorter, cooler Ramadan, but the opposite is seen in the southern part of the equator. So all of these are factors we keep in mind when we assess risks and build programs for safety. And in Islamic practice, Ramadan fasting is a pillar of Islam. And when you tell someone not to fast, they're really devastated because they feel like they're not fulfilling all their commitments towards the religion. And with or without diabetes, patients will choose to fast. And majority of people with diabetes actually fast, even if against medical advice. And what do? We tell them you're on your own, make them sign a piece of paper and let them go? Of course not. We counsel, we educate, we motivate, and if they insist, we make modifications in their medications and we educate them when to break the fast. So let's go over how common is fasting among people with diabetes. There are three landmark trials that looked at that. So the first one is the EPDR study that looked at population from 13 countries, almost 13,000 subjects in this study. 79% of people with type 2 diabetes and 43% of people with type 1 diabetes fast for the majority of Ramadan. So it's common for people with diabetes to fast. Also in the CREED study, also a 13-country study of around 3,300 participants, 64% of people fasted all Ramadan, and actually 94% fasted for at least 15 days or more. And if we look at the Darmina, which are the big collaborative projects that Dr. Hassanein runs with colleagues around the region, in the DAR type 2 diabetes, 1,700 participants were enrolled. And if you look at these people with type 2 diabetes, on average, they fasted 27 days of Ramadan, and 57% of the participants fasted actually the whole month of Ramadan. And also the same group did the Darmina type 1 study looking at 136 subjects, and at least 76% fasted for a day, 72% fasted for 15 days, and 48.5 fasted for 30 days. So we have clear evidence that our patients with diabetes do choose to fast, maybe 15 days, maybe the whole month. So it's their commitment to fasting. And as Professor Hassanin just mentioned in his presentation, and he repeatedly says this in conferences, that education is the most effective intervention for reducing Ramadan-related complications. And he truly said that we do a lot of effort teaching us healthcare professionals, but what we need to do is go back to the patient and educate and empower them on the same knowledge parallel to what we do for clinicians. To understand the impact of fasting on patient physiology, we have to understand a few changes that happen in Ramadan compared to the non-fasting months. So there is alteration in the feeding hours, as we know. If you see in the top panel, people are eating typically breakfast, lunch, dinner, and snacks in between. But when you go to Ramadan, it's abstaining from meals. Then you have one big meal, and then meals, 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 meals until they cannot eat anymore. So in some of us, it's a month of feasting, not a month of fasting, unfortunately. So you can expect from that hyperglycemia immediately post-iftar. You can expect of that hypoglycemia during the hours before iftar specifically, especially the 2-3 hours before iftar. And there is also sleep changes in Ramadan. If you see in the top panel here, you see perhaps people go to bed at 11 or midnight and then wake up and go to work or school, etc. But in Ramadan, they might have a midday nap. They might, of course, have their iftar and eat and then sleep again, wake up for suhoor and sleep again before they go to work or whatever. So this sleep disruption is known to create more insulin resistance, and with that, you might expect higher rates of hyperglycemia, or all in all, you will see a lot of glucose variability and fluctuations. So as you saw earlier from Dr. Hassan's presentation, you see people with an A1C of 9% or more, but still they have their hyperglycemia increased and the hypoglycemia increased because of the changed physiology. So all in all, physiology of fasting is governed by altered meal timing, medication food mismatch, sleep disruption, and overeating at iftar. And when we abstain from eating in people with type 2 diabetes, for example, you don't have that glucose triggering insulin secretion. So subsequently, you have insulin secretion that is decreased, and the metabolism will shift from glucose metabolism to fat metabolism. They will go to other resources of energy. They'll go to gluconeogenesis. They'll go to glycogen breakdown. And all of that can increase the patient risk of either hypoglycemia or alternatively hyperglycemia. And I spend a lot of time in clinic explaining this to the patient in my education because it's important they understand they are worried of hypoglycemia, and for them it's easy and it makes sense to break the fast. But when their glucose is riding high, they feel very comfortable to continue fasting. But this risks them going into dehydration, and with dehydration, you risk thrombosis, etc. And there are studies that show increased DVT and retinal vein thrombosis during fasting and with hyperglycemia, and also DKA, especially with type 1 or insulin deficient type 2. And you've heard also from Professor Hassanein the updated risk calculator to assess patient safety. And that's something important to teach in our patient education. Because when they know why we tell them to fast or not to fast, they're more likely to adhere by it. And what I mostly like about these calculators is it removes from us the subjectivity of opinion. Oh, let me see, will I let you fast or not fast? To an objective measure that's defensible, that's calculated and supported by evidence. And you can easily get the risk calculator online if you want a full access to it. If you scan this QR code, we're still, as I said, waiting for the DAR 2026 full guidelines, but at least the calculator is published here. And after doing the risk assessment, we would categorize the patient in one of three categories, either low risk, and these patients are safe to fast. We do the medical evaluation. We might need to adjust their medication, maybe not if they are on low risk medication for hypoglycemia, and we closely monitor them. And as you see on the third column on the right, you have the religious opinion. And often when we do these education classes in Bahrain Diabetes Society, we bring with us a religious figure because patients want to hear the religious opinion from a religious figure. And these patients are obligated to fast. Medically, you're fit to fast. So they cannot take the advantage of Ramadan unless they have another condition to not fast if they are low risk. The moderate risk are from 3.5 to 6-point score. And here the safety of fasting is uncertain. So I tell them, I'll allow you to fast with caution, which means we will alter your medications, we'll make adjustments. I will monitor you during Ramadan. If feasible, let's put a CGM on you before, during, and after Ramadan. And strictly give them the cutoffs of when to break the fast if hypo or hyper. And then the high risk group is the group that are forbidden from fasting. And I remember when one of the religious figures was there and I was talking in Arabic about this, and he was advising me and guiding me to say specifically, strictly, لا يجوز الصيام, لا يجوز, because you are high risk, not لا يفضل, لا يجوز, because this is forbidden for you. You're putting your life at risk. So there is alignment of what we just spoken about. Again, it's not an opinion. It is supported by evidence and by prestigious societies like the IDF-DAR. Now you see it, as Dr. Hassanein mentioned, in the ADA. And Islamic scholars, like in the DAR document, the last chapter is a statement from Azhar stating the religious support for all these decisions. We know that in Islam, breaking fast is religiously permitted when harm is expected. So, education is super important, and we have to think about it not as an add-on or an option or a nice thing to have. It's a must. It's a patient right that we must educate them, and this is the intervention that can save lives. Do we know that it does work, and does it save harm? Yes, of course. In the EPDR study I referred to earlier, education reduced hypoglycemia. In the READ study, education reduced also hypoglycemia, and CREED, education reduced ER visits. And in the DAR-MENA type 2, education reduced hospitalization, and again in the READ study, education increased safe fasting completion. So education has a very meaningful impact on your patients. And as mentioned clearly in the Diabetes in Ramadan 2021 guidelines, structured education before Ramadan is associated with reduced complication and safer fasting. And it's a core pillar along with the risk stratification, because what's the point of just telling the patient fast or not fast if you don't empower them with the needed education? So if you're teaching or creating a program to educate your patients, what should that include? Risk awareness, so understanding the risk of hypoglycemia, hyperglycemia, ER visits, etc. You teach them about SMBG rules, the timing to test, and that testing will not break their fast, because some people have that misconception that if I test and there's blood, it ruins my fasting. It doesn't. When to break the fast, and we'll elaborate on that in a minute. Basics of nutrition and hydration, telling them if we do what Prophet Muhammad ﷺ did and we eat that way, we will all be in a better shape than what we do culturally here, feasting on carbs and fat. And then education and physical activity, what's the proper time to exercise, and medication adjustment, of course. That's very relevant to our patient to understand the numbers or the cutoffs at which they should break their fast. I remember when I first joined King Hamad Hospital, I was seeing a lady who tells me, when my sugar is low, I just go to sleep, because then I save my energy and I'll be fine until iftar, no matter how many hours. And I'm like, oh my God, she could die in her sleep. So there is a lot of room to improve in education. So blood glucose below 70 or a blood glucose above 300, and again, explain why these numbers to your patients so they can comply with your recommendations. Symptoms of hypoglycemia and acute illness or dehydration. Education should start early, 6 to 8 weeks before Ramadan. It should be individualized, and as you'll see in the coming slide, multidisciplinary, and it's not a one-time thing. People forget from year to year. They forget what they did last year. So repeat it annually. And as mentioned earlier, a lot of these are modifiable risk factors, so you might need to do the risk assessment anyway annually. So who is involved in the diabetes education? Is it the Bahrain Diabetes Society? Is it the health center? Is it the dietitian? All of us. So we're all involved, and a good program will be multidisciplinary program with diabetes trained physicians, diabetes nurse specialists, dietitians, pharmacists, and primary care team. And involving the primary care team in this really makes this applicable and scalable to reach all relevant patients. And whenever you design such an activity, you want to make it structured, you want it to be consistent and very Ramadan specific, because we have a lot of education program for patients about diabetes care in general, but this is specific for Ramadan. And how is it done? It can be done as outpatient diabetes clinic program. It could be done in the primary care clinics. You could do it either as group education sessions or community-based programs like we arrange with the Diabetes Society or through diabetes education centers. Recommendations in general, if you have a high-risk subject who needs more tailored teaching and discussion, you would do individual session. But if you have a group of people who are, say, moderate or low risk, a group education might suffice. Now, we say that it's important. Prof. Hassanain says it's important. Is it truly done? Not really. In the DAR 2020 Global Survey, 43% of participants with type 2 diabetes reported receiving Ramadan-focused education before Ramadan. And when you ask them what form of education did you receive, some will say it is within the clinic session. Some will say it was a structured program, and it could be as simple as a leaflet, a handout that you give to the patient. This is what I need you to read before Ramadan. In a UK-based study, 86% of questioned participants mentioned not receiving any pre-Ramadan education before fasting. That's also true in Saudi. There was a study that showed 70% did not receive any pre-Ramadan education, and this could be because it depends what patients perceive as formal education. Maybe if it's in a classroom, they see it as education. If it's quickly, Dr. Dalal just said, break your fast, do this, do that, it doesn't really count as formal education. A study in Tunisia looked at patients who seek evaluation before Ramadan. 59% of participants asked for counseling before Ramadan fasting, and only 12% reported they have received formal education. So there's a big gap to fill. We have the responsibility, all of us, depending on what area you practice in, we can improve our access to patient and deliver this message clearly as being education about Ramadan fasting. So my key messages to you is that fasting is a personal religious choice of patient, and our job as clinicians is to support their safety. Risk stratification is very important, and education is as important to save lives. There isn't one size to fit all for our patients, and education can be more powerful than just adjusting their medications and telling them fast or not to fast. And a safe Ramadan is not about stopping fasting, it's about educating for it. And perhaps I can invite you if you want further information, in-depth information about all the messages related to medication adjustment, nutrition, etc. Tomorrow, Bahrain Diabetes Society is hosting a webinar. It's free, it's online. You can watch us while you're drinking your tea at home tomorrow at 6:30 p.m. And Professor Hassanain will be one of the speakers. A religious figure will be with us as well. And there are 2 hour CMEs provided, and it's all free, and it's part of the education the Bahrain Diabetes Society conducts regularly. And also something we're very, very excited about, a dream of Dr. Mariam and Sheikh Mohammed and all of us in the society, the big building of a state-of-art education center for people living with diabetes. And a lot of these activities will be conducted actually in our center. It's in Ali, it's ready, and inshallah after Ramadan we'll have a big opening ceremony. And with that, these are my references, and I thank you for your attention.